the thing that I call in my latest book post-racial liberalism. It is liberalism. It's not conservatism. It's not something reactionary. It's not something right-wing. It's liberalism in the sense that it acknowledges the disparity and it sees a role for the state in resolving that disparity. But it's post-racial in the sense that it seeks to avoid any discussion of racism as a contributing factor and thus seeks to avoid the issue of racism as something to which we must turn our attention if we're actually going to solve that problem. But let me suggest before I get into the specifics of it, that colorblindness, post-racial liberalism, whatever term we use for it, is extraordinarily dangerous. It is dangerous as a solution to deal with educational disparity. It is dangerous as a supposed solution to occupational and income disparity. And in the case of health disparity, it's not only dangerous, it is deadly. First of all, if we do not take account of the consequences of color, we cannot solve the consequences of color. So colorblindness, by making it harder to notice the consequences of that thing, in this case color, makes it much more difficult to actually go back and solve the problem. And in fact, not only does it make it more difficult, it could contribute directly to the health disparities and the other inequities that we see. One of the things that bonds every one of us in this room, regardless of race, and regardless of gender and sex and class and religious affiliation or lack thereof, geography, all the different things that make us different, one thing unites every one of us, and that is the secular gospel with which we were raised in this society. And what is that secular gospel? A gospel that is so common that no matter where you grew up in this country, and even if you didn't grow up here, if you moved here, if you've been here for any length of time, you've been exposed to it. What is it? It's the idea that wherever you end up on the ladder of life, it's all about you. If you work hard enough, you'll make it. If you didn't make it, it's your own fault. You should have worked harder. That is the notion of meritocracy, the idea of rugged individualism that we are all fed, even though we all know it isn't quite like that. We all know people who've worked hard every day of their lives and have nothing to show for it in spite of their hard work. And we all know people who were born on third base, convinced that they hit a triple and have never had to work particularly hard at all. So the idea that where you end up is all about you, we know that that's as much myth as it is anything else, but because we've been taught it, we then look around and we see occupational disparity, and we see educational disparity, and we see disparities of income, and we see disparities of health, and our tendency is to do what? Well, if you're raised to believe that wherever you end up on the ladder is all about you, you look at those who are on the bottom of the ladder, whichever ladder it is, whether it's a health ladder, whether it's an income ladder, whether it's an educational ladder, whether it's the ladder of the criminal justice system, and you say, the reason you're down there is there's something wrong with you. Something wrong with you. Your culture is defective. Maybe your genes are defective. You're biologically defective. It's on you. You don't have the same commitment to education. You don't have the same commitment to good health. Your lifestyle is dysfunctional. We tend to blame the victim because the ideology that we're all raised with really sort of points in that direction. And when it comes to health, we're just about the only culture on the planet that actually looks at illness as weakness. That actually looks at illness and actually says, even for 1 second, that the reason we have such problems in health in our country is because, you know, we just have a dysfunctional lifestyle and a dysfunctional culture and it's all about us. Other cultures look at individual causes too, but they're much more given to looking at the systemic. And we tend to look at illness as weakness. That's one of the reasons we don't like to go to the doctor. Much more so than in other countries where actually people, including men, you know, who are the ones who always don't want to go to physicians, right? In other cultures, you know, it's not as common for people to be as afraid, you know, to go to a doctor, but go, oh, I'm okay. You know, we have this rugged individual mentality. That's a larger cultural problem that we often don't address, and we don't address it to our detriment and at great risk. So let's talk about this issue of colorblindness and how in particular it can make health disparities worse by reinforcing this notion of meritocracy, absent any systemic analysis, reinforcing this notion that healthy people are healthy because they just take better care of themselves, and sick people are sick because they don't. And if they want to be healthy, they just need to change them. We just need to fix them. So that young man at St. Joseph, we just need to fix him, not the environment in which he's being educated. We don't have to do anything there. We just need to fix him, teach him coping skills, let him figure out how to get over the hump of the racism that he's experiencing, rather than actually talking about the racism and how we might get at it. Well, right now, 100,000 African Americans every year, according to the CDC and the NIH, 100,000 black folks a year are dying because of excess mortality rates relative to whites. Now, I would be a fool and dishonest were I to suggest that all 100,000 of that excess mortality number is related to racism and discrimination. But one would be equally as foolish and dishonest if you were to ignore the role that it does in fact play. But we tend to have two schools of thought as to what explains that. The first school of thought is that those racial health gaps are the result of economic inequity alone. If people of color have less access to affordable health care, people of color have higher poverty rates, then that will account for the racial health disparities. Barack Obama, the President of the United States, said this in his book, Audacity of Hope, and he has said it again since becoming president. This idea that the best way to reduce racial health gaps is to reduce gaps in insurance coverage and affordability, to reduce poverty, to get the economy working again. The second possible school of thought that's very common is that racial health gaps are the result of either biological or even cultural differences, so that people of color are simply biologically predisposed to certain conditions. We have people who spend hours and hours and months and years, their entire professional careers, trying to prove that which has been disproven for over a half century, that somehow we have such differences racially between us, when in fact most anthropologists and biologists and geneticists worth anything know that race is not scientifically very meaningful at all. But they continue to study it to try to demonstrate, oh, that's the reason that this group has higher rates of heart disease. That's the reason that this group has higher rates of diabetes. Great, maybe we'll make some drug that will specifically fix the biological flaw in black people, they'll say. Again, fixing the victims and assuming that there is something wrong with them, or perhaps it's less healthy lifestyle. So, you know, black and brown folks, they just eat really badly. Well, I lived in New Orleans, Louisiana for 10 years, where everybody eats really badly. Doesn't matter whether they're white, doesn't matter whether they're black, doesn't matter whether they're Honduran immigrants, doesn't matter where they come from. The reality is we as a nation don't eat very healthy, and we don't get enough exercise, and we do have high fat and high sodium diets, but the disparities between the rate at which white folks and people of color engage in those activities is not nearly sufficient, according to the research, to explain the level of health disparities that we are seeing. So then what's left? Well, it's a third theory, and it's one that we don't like to talk about because it raises the specter of racism, and we want so badly to believe we're past it. And that is that the racial health gaps are indeed the result, directly or indirectly, of racism, whether it is individual and direct racism or institutional and structural racism. In particular, two things: disparate treatment received by people of color on the part of physicians dispensing that treatment to them, and secondly, the cumulative effect of racism and discrimination on black and brown health. Now let's talk about that, because I realize it goes against the grain of conventional wisdom. The conventional wisdom, again, of post-racial liberalism, not conservatism, not folks who for their own ideological reasons sometimes have an interest in downplaying issues of racial inequity, but those who in fact talk openly about racial inequity, including, but not limited to, those like the president, who would suggest the best way to reduce racial health gaps is to ensure coverage for all. And yet we know if we look deeply into the subject matter, that's not sufficient. Not that it's not important, but that it's not sufficient. All of these other theories may have grains and kernels of truth, but they will not, in and of themselves, lead us to a less disparate outcome. First of all, know this. The biggest gaps in hypertension, for example, between white and black folks in this country exist at the upper end of the income spectrum, not in the middle and not at the bottom. A study at Meharry Medical College several years back looked at hypertension rates between white folks and black folks, and they controlled for economics. They were only comparing poor with poor, middle class with middle class, upper middle class with upper middle, and affluent with affluent. When it came to those who were poor, there wasn't much difference. When it came to those who were middle class, there wasn't much difference. When it came to comparing middle class with poor, those gaps weren't all that huge. The only substantial gaps in hypertension between whites and blacks emerged when you got to the upper middle to affluent end of the range. In other words, there's something happening with black folks who have good jobs, something happening with black folks who have high occupational status, something happening with black folks who have good incomes that isn't happening to white folks who were in the same occupational strata. Even though those are the black folks most likely to eat healthy, because, you know, eating healthy is not cheap. It's a very expensive thing. So these are folks who are actually in a position to eat healthy, in a position to get exercise, maybe live in a community where there's more access to parks and things where they can do those kinds of things, and yet they're still experiencing substantial differences in overall health. Black women with college degrees, good jobs, health insurance, and decent incomes, having higher rates of infant mortality and low birth weight for their newborns than white women who drop out of school before getting to high school after 8th grade, who tend to not have good occupational status, not have high income, oftentimes not have very good health insurance coverage, except for that which we provide to the poorest of the poor in our country, which is still pretty inadequate. So in every regard, those African American women with college degrees are better off economically within the class system. They're doing better than those white women who dropped out after 8th grade, and yet the children born to those black women are still at significantly lower birth rate and die for their first year of birth at a much higher rate. In fact, when you look at black women and white women, both of whom have college degrees, the infant mortality rates for the children born to black women with college degrees is 3 times the rate for white women with college degrees. So it isn't just about whether they have coverage, it isn't just about whether they have good jobs, it isn't just about their level of income. We also know that black women who had early and ongoing prenatal care all the way through their entire pregnancy, so they had access, and it was primary care, and it was preventative care, and they had all the well baby tests and all that stuff, that those African American women who had access to that, their offspring have twice the infant mortality rate as the offspring for white women who received no prenatal care whatsoever. So once again, when you look at white women who didn't have access, or at least if they did, they didn't avail themselves of it, they didn't get prenatal care, and yet they still are having, those white women, half the rate of infant mortality for their offspring. We know that white women who move up the economic ladder over time actually do see increased health benefits for their offspring. In other words, if white women move up the economic ladder, things do get better, not only for their own health, but for the health of their children. For African American women, as they move up the economic ladder, there's virtually no change. And for Latinas who come from south of the United States border, as they move up the economic ladder, the health outcomes for they and their children actually decline. Right? So even though the economics are getting better, there's something else happening for them, which is different than what's happening for white folks as we move up the economic ladder. And things for us, who are white, improve. We know that black women who don't smoke, so once again, we look at lifestyle factors because everyone wants to talk about that. Black women who don't smoke, who have never smoked, and who do not smoke at all during the course of their gestation of their soon-to-be-born child, have higher infant mortality rates and lower birth weight on average for their offspring than white women who smoke, not only in general and heavily, but all throughout the course of their pregnancy. So once again, not only when folks have coverage, not only when folks have higher occupational status, not only when folks have higher income, but when folks are engaged in healthier lifestyle choices, there is still something happening for these African American women and their newborns. What's very interesting is when you look at African-born black folks and those who have recently come to the United States, what you find is that their health outcomes, both for themselves and for their offspring, are virtually identical to the outcomes for white Americans. Far better outcomes, in other words, than the outcomes for African Americans. So here are African folk right off the continent. So that if there were biological and genetic reasons why black folks were so unhealthy in this country, we'd see it in that population, because that's a population considerably less mixed, quote unquote, historically, going back several generations. They are as black as anyone in the country, and yet they are not manifesting the same